Reducing stimuli. Keep noise around the infant as low as possible. Place incubators away from traffic and congestion areas and avoid talking near the incubator. Use incubator covers to help lower sound inside the incubator. Set alarms per facility policy and respond quickly when they sound. Alarms should be audible but not disturbing to nearby patients. Open and close portholes and doors on incubators and cabinets quietly. Do not place objects on top of the incubator or use it as a writing surface because it increases the noise inside. Teach parents and others to avoid tapping on the incubator. Soft classical music is sometimes used to help promote rest. Lights that are on 24 hours a day in the nursery may interfere with the development of sleep cycles. Position the incubator so the infant is not facing bright lights, and drape a blanket or incubator cover over the top and sides to decrease light and noise further. Use a dimmer switch to vary the intensity of lights as needed. Reduce lighting at night to as low as possible to help promote rest, conserve energy for growth, and help development of circadian rhythms. Some NICU have single rooms for each infant. This reduces noise and allows environmental stimuli to be adapted to each individual infant's needs. It also provides more privacy for visiting family members and may reduce hospital-acquired infections. Promoting rest. When possible, schedule quiet periods when lights and noise in the unit are kept to a minimum to promote rest. Rest periods should be at least an hour long to allow preterm infants to complete a sleep cycle. Only emergency procedures should take place during rest times. Contain the infant's arms and legs to promote flexion and reduce energy loss from flailing extremities. Containment also promotes quieting, improves physiologic stability, and reduces stress. Provide boundaries with rolled blankets or commercial positioning devices placed around the infant. For the side lying and supine positions, arrange the infant's arms and legs in a flexed position, with the hands near midline to allow hand-to-mouth activity and sucking. Stroking and gentle massage may be calming for stable preterm infants. It may help increase weight gain and improve development. It also can help involve parents in care of the infant. Not all types of touch are appropriate for smaller, more fragile infants. However, an appropriate option can be used to facilitate parent-infant interaction. Promoting motor development. Preterm infants may have musculoskeletal and developmental problems from prolonged immobilization and the effects of gravity in their immature neuromuscular system. Because the extensor muscles mature before the flexor muscles, the infant tends to remain in an extended frog leg position. Shoulder retraction, abduction and external rotation of the lower extremities, lateral flexion of the arms, neck hyperextension, and flattening of the sides of the head may be prevented by using correct positioning. Reposition the infant every 2 to 3 hours or when other care is given. Change the position slowly because position changes may be stressful. When possible, position the infant with the extremities flexed and the hands placed in the midline and near the mouth to allow the infant to suck them for comfort. Use swaddling, blanket rolls, and commercial positioning devices to maintain flexion. Individualizing care. Although all NICU nurses are competent in caring for preterm infants, they have slightly different styles in approaching infants. When possible, the same nurse or nurses should be assigned to care for the infant. This allows the nurse to learn the infant's unique behavior and response to stress and allows the infant to get accustomed to the nurse's individual caregiving pattern. It is also very helpful to parents to relate with a small number of nurses who know their infant well. The ability to tolerate stress varies with each infant. Adapt general care according to the infant's ability to tolerate it. Determine the infant's response to various stimuli, particularly those that cause adverse responses. Even positive stimuli, such as soft music or talking, quietly can cause overstimulation at times. Infants often require extra energy to adjust to changes in care. Observe how well they tolerate changes such as moving from assisted to more independent breathing or introduction of new feeding methods. Increase rest periods during these times. Communicating infants' needs. Use the nursing care plan and shift reports to inform other caregivers of techniques that are especially effective for certain infants. Tape laminated notes near the bedside as reminders of needs unique to each infant. Doing so also alerts the parents to the methods that nurses use to care for the infant. Explain all techniques to the parents and solicit their suggestions so they can participate in care appropriately. Evaluation. As a result of interventions, the infant displays fewer and less frequent signs of overstimulation and shows an increasing tolerance to stimuli before signs appear. Application of the nursing process. Nutrition. Preterm infants are born before full accumulation of nutrient stores has occurred or digestive capacity is achieved. The problem increases with decreasing gestational age. Full-term newborns have reservoirs of calcium, iron, and other nutrients, but these are lacking in preterm infants. Fat stores are minimal or absent, and glucose reserves are used soon after birth. Hypoglycemia develops very quickly and should be prevented or treated promptly. Preterm infants receiving enteral feedings need approximately 105 to 130 calories per kilogram per day. This amount varies according to activity, illness, and other factors that may affect caloric need. These infants need more protein, iron, calcium, and phosphorus. The average healthy preterm infant should gain approximately 15 to 20 grams per kilogram per day. The GI tract of preterm infants does not absorb nutrients as well as that of full-term infants. Although they digest protein well, preterm infants have insufficient bile acids and pancreatic lipase to absorb fat adequately. They have some lactase deficiency but rarely have lactose intolerance. Their smaller stomach capacity limits the volume preterm infants can tolerate at each feeding. They need more of many nutrients per kilogram than do full-term infants, and supplementation is necessary. Assessment. Changes in feedings are often made according to the nurse's recommendations, based on assessment of an infant's tolerance of feedings, readiness for change, and signs indicating complications. Assess how well the infant tolerates enteral feedings, whether by Cabbage, feeding tube, or nipple. Aspirate the stomach contents to measure the residual amount of feeding in the stomach before intermittent Cabbage feedings, or every 2 to 4 hours for continuous feedings, or according to hospital policy. This procedure helps determine whether the stomach is emptying and prevents overdistension. Report residuals to the provider if they are more than half the previous feeding for intermittent feedings, or more than 2 to 4 milliliters per kilogram, or a 1-hour volume for continuous feeding. An excessive residual indicates that the amount, type, or flow rate of formula may need to be changed. It also may be an early sign of a complication such as necrotizing enterocolitis, NEC. Unless they are bloody, have large amounts of mucus, or are otherwise abnormal, gastric residuals are often replaced to prevent loss of electrolytes. Abnormal residuals are also reported to the provider, and the feeding may be held. The next feeding may be reduced by the amount of the residual. If residuals are not replaced, observe carefully for signs of electrolyte imbalance. Vomiting or frequent regurgitation may indicate the feedings are too large. Vomitus or residuals containing bile may be a sign of intestinal obstruction and may require surgery. Diarrhea may be caused by too rapid advancement of the feeding or intolerance to the type of formula. Observe for signs of intestinal complications such as visible loops of bowel. Obtain objective data about abdominal distension by using a tape to measure abdominal girth per facility protocol. Place the tape directly above the umbilicus and record the placement to ensure consistency. Stools may be tested for reducing substances, which indicate malabsorption of carbohydrates, or occult blood if feeding intolerance is suspected. Report signs to the healthcare provider because they may be early indications of complications such as ileus, sepsis, obstruction, or NEC. Readiness for nipple feeding. Preterm infants often are initially fed parenterally or by Cabbage. The ability to feed orally and the ability to gain weight are important milestones, as they are often among the criteria for discharge from the hospital. Coordination of sucking, swallowing, and breathing is a complex task for infants. Preterm infants do not have the well-developed buccal sucking pads in the cheeks that term infants use to form a seal around the nipple for efficient sucking. The jaw is less stable, and the infant tires easily during oral feedings. The gag reflex may function poorly. The infant's respiratory status, other problems, and distractions in the environment can greatly affect feeding ability. During Cabbage feedings, watch for signs that nipple feeding may soon be possible. These include rooting respiratory rate below 60 breaths per minute and increasing ability to tolerate holding and handling. Although sucking on the Cabbage tube, a finger, or a pacifier may be a sign of readiness, it is not enough. Infants should also have an intact gag reflex, or they are more likely to aspirate feedings. Note whether the infant gags on the catheter or a gloved finger inserted into the mouth. Most infants are ready to begin oral feedings when they reach 34 weeks gestational age. Some are ready as early as 30 weeks and others need until 36 weeks. At this age, many healthy preterm infants are able to coordinate sucking with swallowing and breathing and have a functional gag reflex. In addition, infants must have enough energy to feed orally without compromising oxygenation. Very weak infants expend too much oxygen, glucose, and energy when sucking and must continue to receive Cabbage feedings. By 30 to 32 weeks, feeding readiness assessments should be initiated. When the infant begins to feed by nipple, assess coordination of suck, swallow, and breathing and observe for aspiration. Frequent choking, gagging, or cyanosis during feedings may indicate that the infant cannot coordinate all feeding movements well enough for nipple feeding. In many infants, signs of aspirations are minimal or absent. This is called silent aspiration. Assess the respiratory rate before and during feedings. When the respiratory rate is more than 60 breaths per minute before feedings, Cabbage feed to prevent aspiration. During feedings, observe for signs that the effort of nipple feeding requires too much energy and oxygen for the infant. Identification of patient problems. When the infant's nutritional needs are met by parenteral methods, the nursing care is collaborative. However, once the infant is able to breastfeed or take formula by bottle, many nursing interventions are involved. They include the potential for ineffective feeding because of uncoordinated suck and swallow, as well as fatigue during feedings. Planning expected outcomes. The expected outcomes are that the infant will do the following. 1. Consume adequate amounts of breast milk or formula to meet nutrient needs for age and weight. 2. Gain weight as appropriate for age, generally 15 to 20 grams per kilograms per day. The actual amount of feedings and weight gain will vary according to the infant's gestational age and other conditions. Discuss what is appropriate for a particular infant with the physician or nurse practitioner. Interventions. Administering parenteral nutrition. The nurse manages the administration of total parenteral nutrition, TPN, the IV infusion of solutions containing major nutrients needed for metabolism and growth. It may be necessary for very immature infants because of respiratory problems, limited gastric capacity, surgery, or reduced peristalsis. It provides calories, amino acids, fatty acids, vitamins, and minerals in amounts adapted to the specific needs of infants. TPN is decreased as enteral feedings are increased, continuing until the infant is able to tolerate full enteral feedings. Administering enteral feedings. Enteral feedings feeding into the GI tract orally or by feeding tube are usually begun within the first few days with minimal enteral feedings, also called trophic feedings. These feedings are only a few milliliters of breast milk or formula given at a time. They stimulate development of the GI tract, enhance gut motility, decrease the need for parenteral nutrition, and decrease feeding intolerance. Bowel sounds should be present. There should be no significant abdominal distension, and infants should be in relatively stable condition. Mother's milk is preferred if it is available. Donor breast milk also may be used. Colostrum is especially high in immune agents to help prevent infection. Feedings are gradually increased according to the infant's tolerance. Colostrum or breast milk also can be used for oral care of infants. It is applied to the infant's lips and inside of the mouth every 3 hours with a sterile swab. It provides the immunologic benefits of breast milk before the infant can take feedings. Preterm infants need special formulas or fortified breast milk. These formulas are adapted to meet the need for easily digestible, concentrated nutrients in a smaller volume of fluid. Preterm infants may need formulas that have 24 calories per ounce or more instead of 20 calories per ounce used for the full-term infant to meet these requirements. Preterm formulas may contain added calories, protein, vitamins, minerals, and complex fatty acids. Other components may be added to meet individual needs. Breast milk fortifiers add needed nutrients to breast milk. Administering Cabbage feedings. Cabbage feedings are usually started before oral feedings for preterm infants. Small, soft catheters inserted through the nose or mouth every 2 to 3 hours for intermittent bolus feedings. An indwelling catheter also may be used to provide for intermittent or continuous feedings. Indwelling catheters stay in place up to 30 days. Inserting a catheter at each feeding may be more traumatic than leaving it in place. Frequent oral placement may cause vomiting or increase infant aversion to oral stimuli, which may lead to difficulty with oral feedings later. Vagal stimulation during insertion may cause apnea and bradycardia. Nasal placement avoids aversive oral stimulation, but may increase airway resistance by interfering with airflow through the infant's small nasal passages. Intermittent bolus feedings provide a more normal feeding pattern with periodic stimulation of gastric hormones and enzymes. They should be given slowly over 30 to 60 minutes. Continuous feedings may be better for infants with short bowel syndrome, congenital heart disease, or intolerance to bolus feedings, or those recovering from NEC. However, continuous feedings carry a higher risk for aspiration because the infant is not observed at all times during the feeding. In addition, bacteria counts in the milk or formula may be too high, and fats tend to adhere to the tubing during continuous feeding. Feedings are gradually increased according to the infant's tolerance. Carefully observe the infant's response at each feeding to determine when the feeding type or amount can be changed. Parenteral nutrition continues until the infant is able to take adequate enteral feedings. Pacifiers are often used during Cabbage feedings. Preterm infants have been exposed to noxious oral stimulation, such as intubation and suctioning. As a result, they may react negatively to any additional oral stimulation, which interferes with feedings. Providing a pacifier during Cabbage feedings gives positive oral stimulation and helps associate the comfortable feeling of fullness with sucking. Non-nutritive sucking increases later success in oral feedings and decreases behavior changes during feedings. Non-nutritive sucking also can be provided by having an infant who is not ready for oral feeding suck on the mother's emptied breast as a way to prepare for feeding from the breast. Cabbage feeding can be done at the same time to help infants associate the breast with the feeling of being fed. This may improve breastfeeding ability when the infant is ready to be fed at the breast. Administering oral feedings. Oral feeding should be cue-based, begun when the infant shows signs of physiologic and behavioral readiness to feed, rather than on a time schedule. Crying is a late hunger sign and may cause the infant to be too tired to eat. The frequency and volume of oral feedings are based on the infant's readiness and ability. Oral feedings may be offered at each feeding time if the infant shows positive feeding readiness signs. Full oral feedings are reached faster using cue-based feedings. Cue-based feedings may help infants develop a sleep-wake cycle and begin to self-regulate better. Feedings. Provide for maintenance of heat during feedings. When infants have stable temperature maintenance, wrap them in warm blankets and hold them for feedings. If thermoregulation is a problem, feed the infant in the radiant warmer or incubator. Nipple feedings involve a greater expenditure of energy by the infant than Cabbage feedings. Allow for a period of rest before and after feedings. Use of a pacifier before feedings helps bring preterm infants to an alert state that enhances oral feeding success. Infants take feedings better if they are awake. Assess for signs of overstimulation and stress during feedings. If they occur, stop the feeding and let the infant rest. If the infant continues to show signs of stress, The feeding should be completed by Cabbage. Choosing a nipple. A variety of nipples for neonates are available. Soft, high-flow nipples, preemie nipples, are more pliable than regular nipples and require less energy for sucking. However, they may deliver milk too rapidly, cause choking, and interfere with breathing between sucking bursts. Standard nipples are firmer and deliver the milk more slowly so the infant can control it more easily. Nipples are available in several sizes, including those for infants with a very small mouth. Facilitating breastfeeding. Breast milk is best for almost all infants and especially for preterm infants. The non-position statement states human milk and breastfeeding are essential components in care of critically ill newborns. The AAP recommends that all preterm infants receive human milk. Explain to parents that the immunologic benefit of breast milk are particularly important to the preterm infant who did not receive passive immunity during fetal life. Human milk provides protection against infections and decreases the incidence of NEC. Breast milk may stimulate the immune system and GI maturation. It is well tolerated and the nutrients in it are more available than those in cow's milk formulas. Nutrients in breast milk are more easily digested and it provides antimicrobial components, enzymes, hormones, and growth factors important for the preterm infant. In addition, breastfeeding may be less stressful than bottle feeding for preterm infants. Oxygenation levels are often higher during breastfeeding because the infant can regulate breathing and suckling better than with bottle feeding. Offer support and encouragement to mothers who want to breastfeed. Contributing her milk helps the mother realize she has something important to offer at a time when she may believe she can do little to help her baby. Many mothers find this particularly rewarding and worth the effort involved. They may develop a sense of increased control when they are able to breastfeed and may take on more responsibility in infant care. The mother who plans to breastfeed needs help with maintaining lactation till the infant is mature enough to nurse. Help her begin to use a breast pump as soon as possible after birth and instruct her to pump at least 5 times a day for 20 minutes per pumping session or a total of at least 100 minutes per day. The Ahwan considers providing a breast pump and instruction to mothers of preterm infants within 6 hours of birth a nursing care quality measure. Give the mother sterile containers to store her milk. Show her how to label her milk and where to take it when she brings it to the NICU. When she goes home, tell her to place her milk in a refrigerator if the infant will receive it within 24 hours or in a freezer if it will be more than 24 hours. If fortifiers will be added to the milk, explain the higher needs of the preterm infant so that the mother does not think something is wrong with her milk or that it is inadequate. In some facilities, healthy preterm infants progress to breastfeeding from Cabbage feedings without using the bottle at all. This should be encouraged with eligible infants and mothers who desire breastfeeding. Ongoing support for the mother is important. Encourage her efforts in feeding, which may be difficult at first. Remind her that even full-term infants must learn how to breastfeed. Mothers who have not breastfed previously have to learn the basic techniques and also how to adapt them for the preterm infant. Relaxation needed for feeding is difficult in the busy NICU. Provide as much privacy as possible using a separate room or screens. Help the mother feel comfortable holding the tiny infant and any attached equipment. The presence of a lactation consultant during initial breastfeeding sessions is very helpful. Adapt breastfeeding teaching to the needs of a very small infant. Show the mother how to use the football and cross cradle holds, which allow her to see the infant's face well during latching on and throughout the feeding. A supplemental nursing system, a device that holds expressed breast milk in a bag with a small tube attached to the mother's nipple, may be used to help infants receive more milk with less effort during early feedings. Feeding should begin gradually and progress similar to initial bottle feedings. Make the same observations of the infant during breastfeeding as during bottle feeding. Signs of fatigue, bradycardia, tachypnea, or apnea may show lack of readiness for breastfeeding. Be sure the infant stays warm. The mother's body will help maintain the infant's temperature during feedings. KC is often started before the infant is able to breastfeed. As the infant becomes ready to breastfeed, KC can be continued during the feeding. Thin nipple shields may be used in the first few days of breastfeeding to help the infant latch onto the breast and remain latched. Instruct the mother to pump her breasts at the end of each feeding because preterm infants may not suckle well enough to extract all milk from the breast at first. Making ongoing assessments. Continuously assess the infant for feeding readiness cues and the infant's response to all feeding methods. Watch for signs of distress, especially when feedings are first initiated. Record the amount of breast milk or the amount of formula the infant takes by gavage or bottle and compare it with the amount needed to meet nutrient needs for the infant's age and weight. Because accurate estimation of milk intake is difficult during breastfeeding, infants may be weighed on an electronic scale before and after feedings to determine intake. Both weights should be taken with the infant wearing the same clothing and before the diaper is changed after the feeding. The difference in the weights in grams equals the milliliters taken. This allows supplementary gavage feeding amounts to be calculated on the basis of the infant's oral intake of breast milk. Note the infant's response to other stimuli during feeding. Some infants respond well to being talked to and rocked during feedings. Others become distracted by any noise, motion, or nearby activities. Weigh the infant daily at the same time with the same scale. Record the length and head circumference each week. Plot measurements on a growth chart for preterm infants and compare results with expected ranges. Weight increase not accompanied by increased length may be caused by edema and may be a sign of a complication such as congestive heart failure. Observe changes in the infant's ability to take feedings. The suck and swallow coordination should gradually improve with maturity and practice. As the infant becomes more mature, less energy should be expended during the feeding sessions. The infant will take the feedings more quickly and show fewer signs of fatigue, such as falling asleep during feedings. Explain to the mother that she may need to continue to pump her breasts after feedings several times a day after the infant goes home. The infant's suck may still be too weak to adequately stimulate milk production. Pumping helps maintain the milk supply. The need to pump will lessen gradually as the infant nurses more vigorously. Evaluation. If the expected outcomes have been met, the infant will consume adequate amounts of breast milk or formula to meet nutrient needs for age and weight and will gain weight as appropriate for age. Application of the nursing process. Parenting. The birth of a preterm infant is generally unexpected and always emotionally traumatic to parents. Infants are often hurried to the NICU shortly after birth. Later, when parents go to the NICU, the infant is attached to an array of machines. Parents cannot hold or feed the infant at first, or offer any of the usual care that parents expect to give their infants. The infants may not be capable of common newborn behaviors such as making eye contact and grasping the parent's finger. When the infant's appearance and behavior are different from the parent's expectations, attachment may be delayed. The extended hospitalization of the preterm infant causes separation of the parents from their newborn, produces emotional trauma, and disrupts family life. Parents must relinquish the role of primary caregiver during their infant's hospitalization. They may feel they are in the nurse's way and may state they do not feel like parents at all. Loss of the parental role is a major stressor for these parents. Being unable to participate fully in the infant's care for a prolonged period hampers the parent's ability to learn their baby's unique characteristics, such as the way the infant responds to stress and the methods of consolation that work best. Separation delays the development of the parent-infant relationship and may impair bonding. In addition, parents worry about the infant's condition and outcome. They need help in understanding the infant's condition and what can be expected to occur throughout the hospital stay. Nurses should evaluate the progress of attachment to assist parents to feel important in caring for their infant. Assessment. Assess for signs of parental attachment on the first and subsequent visits to the NICU nursery. Expect parents to be fearful at first, but more able to focus on the infant as they recover from the initial shock of preterm birth. Assess for common behaviors that show normal progression of attachment. These include talking about the infant in positive terms, making eye contact, pointing out physical characteristics, naming the infant, and calling the infant by name. Parents should ask questions about the infant. When they are able to hold and participate in the care of the infant, observe for gradual increase in comfort and skill. The parents should smile and talk to the infant and verbalize increasing confidence in their caregiving abilities. Watch for signs that bonding is not occurring as expected. These include failure to show usual attachment behaviors or a decrease in behaviors that were previously present. Parents who seem as interested in other infants in the NICU as in their own infant or talk about the infant in an impersonal way may be having difficulty. Note how often the parents make visits or calls to the NICU and changes that may indicate their need for support. Determine whether there are other stressors in the parents' lives that may interfere with their ability to visit and form attachment to the infant. The financial need to return to work, lack of transportation, long distances, or the need to care for other children may prevent parents from visiting as often as they would like. After the critical period in the early days after birth, healthy preterm infants become more stable. They still require specialized nursing care and hospitalization, but gradually need fewer technologic interventions. They are sometimes called growers at this time. This is a time when parental participation in the infant's care should increase in preparation for discharge. Identification of patient problems. For parents of preterm infants, an important patient problem is the potential for inadequate development of parent-infant relationship resulting from lack of understanding of the infant's condition and separation from the infant. Planning expected outcomes. The expected outcomes are that the parents will do the following. 1. Demonstrate bonding behaviors, including visiting or calling frequently and interacting as appropriate for the infant's condition throughout the hospital stay. 2. Verbalize understanding of the preterm infant's condition and characteristics within 2 days. 3. Express gradually increasing comfort in participating in infant care throughout the hospital stay. Interventions. Making advanced preparations. Preparing for stressful situations such as preterm birth helps parents cope with the actual event. Parents at higher risk for a preterm birth should visit the NICU before delivery. If the mother is confined to bed, arrange for a nurse from the NICU to visit her so that she feels a link with the nursery. The father or another support person should tour the nursery so that he can discuss the nursery environment with the mother. Encourage the parents to ask questions. Assisting parents after birth. After the birth, allow the parents to see and touch the newborn in the delivery room, even if only for a few moments, so they have a realistic idea of the infant's appearance and condition. This helps the bonding process that began in pregnancy to continue. If possible, allow the father or a primary support person to watch the initial care in the NICU. Explain what is happening and why. This attention allows him to see the intense efforts made on behalf of his infant, increases his confidence in the staff, and enables him to give the mother a full description later. Support the father as well as the mother by using therapeutic communication during this difficult time. If the infant must be transported to another facility, ask the transport team to visit the parents before leaving, if possible. The visit helps parents feel connected to their infant and to the staff providing care. Leaving photographs with the mother is another way of helping her bond, even though the infant is not with her. Supporting parents during early visits. Take the parents to the NICU as soon as possible. If the mother is too ill to be with her infant, bring her photographs. Before parents first visit the infant, prepare them for what they will see. Describe the equipment, the various attachments to the infant, and the purposes. Explain how the infant will look and behave. Box 23.1 provides specific steps that the nurse can follow to help parents become familiar with the NICU setting. At first, stay with the parents during visits. When they are comfortable, allow them time alone with the infant so they can interact in private. Answer questions and explain changes in the infant's condition and treatment. Expect to repeat explanations because stressed parents may not understand or remember what was said. Parents often do not know what questions to ask at first or are too overwhelmed to ask questions. In this situation, discuss questions that are common when parents first visit the NICU. Use therapeutic communication as the parents cope with their grief, guilt, and emotional turmoil. Parents should touch the infant as soon as possible because touching helps promote attachment. They may be hesitant initially because of fear they will interfere with the equipment. The smaller the infant, the more reluctant the parents may be. Some parents may hesitate to touch because they are afraid of becoming attached to an infant who may not live. They need sensitive support from the nurse until they are ready to progress in the relationship with the infant. Show parents how to touch in ways appropriate for the infant, such as holding the infant's hand through the portholes of the incubator or touching the small areas of skin not encumbered by equipment. Explain that handling is kept to a minimum for physiologically unstable infants because it is too stressful to them. As the infant becomes more stable and mature, show parents which forms of touch work best with their infant. This helps parents feel more a part of the infant's plan of care. Help the parents hold the baby as soon as possible. Parents often look forward to the opportunity to hold the baby as a positive sign of the infant's condition. Yet it is frightening too, especially if the infant is attached to various kinds of equipment. Help the parents find a comfortable position for themselves and the infant and point out positive responses for the infant. Supporting the father. Nurses often concentrate on the mother in providing support. However, fathers also must deal with the shock of having a preterm infant in the NICU. They need support in learning about their infant and how to parent. One study showed fathers of NICU infants had elevated levels of stress and symptoms of depression throughout the 7 weeks of the study. In addition, fathers may have work responsibilities, are expected to provide emotional support for the mother and explain the condition of the mother and the infant to friends and family, and may take on other family responsibilities as the mother focuses on care of the newborn. Fathers may spend less time in the NICU because of other responsibilities, but may have many questions and concerns. If their time for visiting is limited, fathers may be less comfortable than the mother for caregiving activities. Encourage them to participate in hands-on care whenever possible. Compliment both parents as they care for the infant so they are encouraged to participate even more. Providing information. An important role of the nurse is providing accurate information to parents. Allow parents to express their concerns before beginning to teach. Encourage them to ask questions about all aspects of their infant's condition and care. Although some parents are not hesitant to ask questions, others may avoid asking for explanations or advocating for their need to care for their infants because they are afraid they might be seen as difficult or demanding parents. Let the parents know their questions are welcome, and do everything possible to give them the answers when they do ask questions. Give information about common concerns if the parents do not ask questions. Explain the equipment used to care for the infant. Interpret the information obtained from monitors and the meanings of alarms. Clarify all nursing care, its purpose, and the expected response. Point out how preterm infants are similar to and different from full-term infants to help parents develop an accurate understanding of the infant's capabilities. Offer realistic reassurance about the infant's condition, emphasizing positive aspects while being truthful. If the parents have misconceptions or do not understand the physician's explanations, clarify or ask the physician to go over specific information again. Translate medical terms into words the parents can understand. Avoid using medical abbreviations and acronyms. Repeat explanations, especially at first. Because of their emotional distress, parents are often unable to fully comprehend or remember what is said to them. Use an interpreter if the parents do not understand English. Even if the parents speak English, if it is not their primary language, they may have difficulty understanding the information. Provide an interpreter as needed. Offer written information about NICU policies and procedures in the parent's language. Explanations about visiting hours, who can visit, routines for hand washing, and the role of parents can be reinforced in writing, so they are available for later reading by overwhelmed parents. Instituting Kangaroo Care. Parents need to feel they can contribute to the care their infants receive. One way to do this is KC. Begin KC as soon as possible if the parents are interested. KC is a method of providing skin-to-skin contact between stable preterm infants and their parents. During KC, the infant, wearing only a diaper and hat, is placed upright under the mother's clothes between her breasts. A blanket is placed over them both. Mothers may breastfeed if they wish and if the infant is able. Fathers are encouraged to participate in KC. The infant is monitored for changes in vital signs and behavior. Explain the advantages of KC to parents and elicit their participation. This method of care has been found safe for stable infants, even if intubated. It provides an opportunity for parents to participate in the infant's care and increases parental attachment. KC provides developmental care that is so important for the preterm infant. It is associated with stability of vital signs, increased weight gain, shorter length of stay, more quiet sleep, and less crying. It also promotes thermoregulation and bonding, and it helps relieve pain. The upright position of the infant against the parent's chest makes breathing easier. The containment of the extremities decreases purposeless movements that use valuable oxygen and calories. Breastfeeding is facilitated and the infant has more alert periods and increased deep sleep. The contact with the parent's skin maintains the infant's body temperature. In addition, KC enhances early and long-term maternal-infant interaction and maternal confidence and competence. KC also provides gentle stimulation. This includes tactile stimulation against the parent's skin, auditory stimulation as the infant listens to the parent's heartbeat and voice, and the vestibular stimulation of moving with the parent's breathing or rocking. Provide privacy for parents interested in KC. Assist them following facility protocol in transferring the infant from the bed, managing the attachments, and making the infant comfortable. Also, check to see that they are comfortable. KC should last at least an hour to improve the infant's sleep. Facilitating interaction. Preterm infants often have little facial expression and seldom make eye contact. Parents may feel rejected by the infant's lack of response or by negative responses during interactions. Explain that the interaction that is so effective with full-term infants may be too stimulating for very young or sick preterm infants. Suggest forms of touch and interaction based on the individual infant's capacity. Quiet holding may be better until the infant is able to tolerate more stimulation. Help parents understand the infant's behavior and cues. Teach them signs of overstimulation to help them adapt their interaction to meet the infant's needs. Explain that these signs help protect the infant from overstimulation and show that the infant needs a quiet rest period without added stimulation. Discuss methods to avoid too much stimulation and to calm the infant. If several types of simultaneous stimulation, such as rocking, eye contact, and talking, cause signs of distress, suggest they stop one or more activities until the infant has had a period of rest. In learning to provide comfort care, parents may go through stages. At first, they are afraid to touch the infant. They spend time just observing the infant before they feel comfortable enough to touch the infant. When they begin to participate in caregiving, such as changing a diaper, their confidence grows. Parents become more confident in their ability to recognize when the infant is uncomfortable, and their skill is comforting their infant. Teach parents how to soothe infants when they show signs of stress. Explain containment and demonstrate how to do it. Placing the palm of the hand over the infant's chest or holding the infant's arms on the chest may help quiet the infant. Show the parents how to position the infant with the hands near the mouth so the infant can suck on them as a self-comforting measure. As the infant is ready for more interaction, suggest appropriate types of stimulation. Point out small signs of improvement and even minor strengths. Talk about normal preterm characteristics and emphasize individual traits that make this infant different from all others. The way the infant eats, reacts to sounds, or seems to get tangled in the monitor leads may help parents feel closer to their newborns. Involve the parents in care of the infant as soon as possible to help them gain a sense of control. Plan to change the linens in the incubator or radiant warmer when the parents are there so they can hold their infant even if only for a few moments. Save baths and other routine caregiving for times when parents can be present and participate. Taking an auxiliary temperature is something that a parent can be taught to do for even a critically ill infant that does not disturb the infant but fosters a feeling of contribution in the parent. As the infant's condition improves, parents can develop skill in caring for the tiny infant by changing diapers, feeding, and bathing. In some NICUs, infants who are stable, who weigh more than 1,000 grams, and who do not need phototherapy, an umbilical catheter, or chest tubes are dressed in normal baby clothes. This helps them appear more normal to parents and assists in attachment. Parents use hospital-supplied clothing or bring their own and enjoy the opportunity to dress their infants. Include other family members by allowing them to visit with the parents. Being able to see the infant in the hospital setting allows family members to provide the parents with more realistic emotional support. Involve family members in learning how to feed and care for the infant if they will be helping the parents after discharge. In some facilities, parents and, in some cases, grandparents are allowed to visit at any time of the day or night. They may be asked to leave during reporting or be invited to stay and participate to help them feel more a part of the infant's care. Web cameras are used in some NICUs to allow parents to see their infants from their homes or from the hospital room. A web camera is placed over the infant's bed, and parents use a computer to access a secure website to see their infant. The camera may be on continuously or only at certain times. Parents can share the website with family and friends so they can see the infant as well. Families report being very satisfied with this opportunity.